All right, Tim, you ready to go?
I am indeed. Good afternoon, everyone. For new commission members who I haven't had the pleasure of meeting, my name is Tim Rourke. I'm a managing director at Third Horizon. We're an advisory firm that's been working with the ADPC in the development of the comprehensive plan. So it's a great pleasure to get a little bit of face time with all of you one more time, including new members. We're also going to be working a little bit with Wes and Debbie, continuing into this year relative to the prevention strategy around House Bill 3321. So we're a group of people that will continue to be in the orbit of the ADPC for this year as well, and we're very excited to do that. Um, I was asked by Annalise and Tony to provide you all an overview of HR1, and as Tony said, a bit of a federal snapshot around some things that are coming down the pike that will impact substance use disorder services in the state of Oregon. So, what we thought we would do is I'll just take a little bit of time to walk through HR1, which was known as the Big Beautiful Bill, and walk through a couple of the highlights of its impact on substance use services, both nationally and specific to Oregon. Certainly, there'll be a window of time for some questions if folks have them. Definitely agree. This is something that situational awareness is really important for all of you going forward because there will be impacts on the provider community, on individuals who are seeking care, as well as to OHA and other state agencies who need to navigate some of the impacts of some of the changes in the bill. So, with that, I'm going to throw up a presentation here and I'll run through it and then take some questions. Can everybody see my screen okay? All right, got some thumbs up. We've had some connection. I'm on the East Coast for those of you that I don't know, and we've had it's a bit of a windy day. So I'm going to shut my camera off as I present just to make sure I don't lose connectivity. But please wave if you suddenly stop hearing me, and I'll hopefully get back on. So we're going to talk about again HR1, which is the big beautiful bill. It was passed by Congress last year. It has a significant. It's an omnibus bill or a Christmas tree bill, which means it's got a ton of stuff in it on a number of different horizons. We're going to stick really closely to its impact on substance use services, but it has impact in other areas that will certainly have consequence to the citizens of Oregon. But we're just going to talk about its substance use impacts today. So, why this bill matters? This bill matters because, at a high level, it makes really significant changes, in particular to Medicaid. And Medicaid in Oregon, like in many other states, is a dominant payer for substance use disorder treatment services. And so some of the changes that are here could potentially have a really outsized impact for folks who are on Medicaid. There are also, which we will talk about, some implications in commercial insurance as well. So even those who might have private insurance or insurance through an employer are going to see or are seeing some impacts of this bill, which I will touch on because certainly they will impact those who are commercially insured who seek substance use treatment as well. The changes affect coverage, it affects the financing of the delivery of services, and it directly affects provider operations. And we're going to talk about all of that. I want to preface by saying a lot of what I'm going to talk about is probably bad news or news that is a little cautious around some things that are going to be really challenging for the field. But there are a couple of other elements that are actually not necessarily negative that we'll touch on as well to know what's coming down the pike for you all this year. So let's hover first on Medicaid. Probably the most significant impact that folks have been thinking about or hearing about a lot is that beginning in 2027, Medicaid will have what's a work requirement. There has been efforts to put work requirements in Medicaid at the state level in several states across the U.S. Very few examples that have been implemented with really any significant track record in them, but this will become a national requirement in 2027. What's important relative to behavioral health is that although there is a Medicaid work requirement that will get underway and go into effect, there is an exemption in HR1 around folks who meet a qualification for something called medical frailty. And if you meet the qualification of medical frailty, you are exempt from the work requirement. There are a list of conditions that need to be met in order to meet that exemption. One of them is having a substance use disorder or a mental illness. So, on the one hand, the work requirement impacts may be mitigated for those who have a substance use or mental illness issue. However, um, that definition of medical frailty is likely to be left to states. CMS is delivering guidance. There are states who already have medical frailty language in their state Medicaid programs that incorporate or include ongoing behavioral health conditions as an exemption. Um, but they are different state to state. And so, what we are aware of is CMS is going to provide guidance to all states as to how they could potentially define medical frailty, elevating some models in different states. Um, in our analysis, we did not find Oregon having a definition of medical frailty. Now, given that you don't have a work requirement, that wouldn't entirely be a surprise. But if you do not have one, or if you have one and it does not include an exemption for substance use or mental illness, Oregon would need to adopt or change its exemption or create a new exemption to ensure that those patients would not be adversely impacted. The other piece I would just say around this work requirement exemption is how that gets activated, at what point someone could claim an exemption, not just the qualifying indications, but the administrative process around how you would file for an exemption is entirely up in the air. So that becomes part of, I think, another challenge that's going to come out of HR1's Medicaid regulations around this next piece, which is verification and just administration of being eligible for Medicaid in a given moment. So, folks may be aware if someone is eligible for Medicaid, typically they have to go through what's called a verification process even after they're enrolled. And that is to determine that they continue to qualify for Medicaid in an ongoing way. In most states, that verification process is done annually. However, in HR1, that verification process actually shrinks and requires verification every 6 months if you're in the expansion population. So what that means is for a number of individuals who are on Medicaid, rather than just the once a year renewal of their Medicaid eligibility, they'll have to go through a renewal process every 6 months. As you can imagine, that has incredible administrative burden impacts on state agencies that have to go through that verification program process. It also creates another administrative hurdle for individuals who are on Medicaid. And it's been a concern for many advocates in that additional verification or added steps to the enrollment process for individuals could create administrative burden and confusion that might lead people to lose their coverage even if they are eligible for Medicaid. The other element that comes up is that retroactive eligibility has been reduced. So in most territories, there is the ability to, if someone applies for Medicaid, they can apply retroactively for, say, in New Hampshire, 6 months. The retroactive eligibility going forward will be reduced, probably in some instances, to 2 or 3 months. So that means that an individual will have less opportunity, or a provider, if someone comes in who's been providing services who is Medicaid eligible, your ability to retroactively bill will be reduced because of the reduction in that retroactive eligibility that is covered by HR1. Couple of other pieces that are important. All in all, there is increased administrative burden in the tracking of Medicaid. That burden is going to fall to states, it's going to fall to providers, and it's going to fall to individuals. There are a lot of provisions, particularly at the state level, around increasing auditing requirements for states. Congress has been concerned about fraud and abuse within the Medicaid program. So HR1 puts in additional auditing requirements for states to provide financial and auditing reports to CMS to ensure that fraud and waste is being reduced within state Medicaid programs. It's unclear exactly what those audits will entail beyond what they do right now. However, what that likely means is in addition to whatever additional reporting or data analysis states are going to have to do, it is likely that that may translate into additional reporting requirements for providers who are who bill Medicaid at the state level to report into the state so the state can meet those additional reporting requirements. All of this, right, is going to lead to what we call churn. In addition to the administrative burdens at the state, local, and provider level, you have changes to eligibility and the cadence that people can apply and need to be verified for eligibility. There is an anticipation of a lot of people, as I alluded to earlier, losing coverage, not necessarily just limited to those who authentically no longer meet the coverage requirement, but potentially those who are Medicaid eligible, but they either miss the reporting requirements or are overburdened and don't submit the necessary materials at validation, for instance. What does that mean to providers? That means increased in no-shows. That means treatment loss, mid-treatment coverage losses for folks who might be in active treatment. Again, even though there's going to be provisions that will allow folks in substance use treatment to qualify under medical frailty, there will probably be some sort of administrative process to demonstrate that. So providers could be faced with instances where individuals temporarily lose their coverage and there needs to be some work to get it back, which has all sorts of implications from provider administration and the delivery of care. The Oregon Primary Care Association estimates that between 100,000 and 200,000 Oregonians are estimated to lose coverage because of these changes within Medicaid. So what we anticipate then, obviously, as a direct consequence, would be an increase in uncompensated care across the healthcare spectrum, not just in behavioral health. And potentially, because people are uninsured again, an increase in the utilization of crisis-oriented services. So to the extent that in the substance use and behavioral health arena, we've seen people improve access to care because of expanded coverage, we might see an increase in people showing back up in crisis situations, in mobile crisis units, in emergency rooms, et cetera. There are also implications for providers. And so one of them is a tax cap that is going to be put in place that does impact providers in the state of Oregon, that reduces the tax from 6% to 3.5% by this federal fiscal year. So that means a potential loss in revenue and a loss in funding. Oregon is estimated to lose over $600 million during federal fiscal year 27 through 29 because of this tax cap reduction. What does that mean on the ground? It means that CCOs will feel increased pressure on rates and on coverage. So how Medicaid manages that in states is an open question. There could be reductions in rates or reduced rate setting. There could also be coverage gaps. We've seen some states who are dealing already with challenges in their Medicaid budgets begin to reduce covered services while still trying to stay on the right side of parity. But we certainly do expect that there could be a real challenge in the ability of Medicaid to viably support a broad swath of behavioral health and other services going forward if these kind of reductions come to pass. Couple of other things that are going to happen, again, that impact both providers and individuals. The first is there is also within Medicaid cost sharing that will begin. What that means is in most states, there are no copays for Medicaid, right? There's an effort to make sure that Medicaid covers people without having to create an outsized economic burden on individuals with copays and things of that nature. There will be cost sharing requirements. So again, for folks who are on Medicaid, for whom their economic picture is not strong enough, that could again be another driver to people leaving care or leaving coverage because they can't afford those cost sharing requirements. We definitely anticipate, and this will segue into some stuff that's happening on the commercial side, but obviously, as people get into the workforce and get better in terms of health, there is always the hope, right, that people move from Medicaid into commercial insurance or into the marketplace. Some of this is going to create some challenges with that, and even if someone may no longer meet criteria for eligibility for Medicaid, However, they might meet eligibility to get commercial insurance, as we're about to talk about, and I'm sure you've heard in the news, there are challenges with access to commercial insurance through the marketplace that I think are concerning for folks that might make that transition even harder, particularly for this population. And then again, just we see all of this again, a theme that for those in treatment, for those seeking treatment, these things could create a snowball effect that we might see real challenges in people's ability to sustainably engage in treatment, particularly long-term treatment, where they may bump up against these eligibility and other things that might get in the way of continuity of care. Couple other things I want to mention on Medicaid. First, and this is not to suggest that Oregon does this, but it's important across the healthcare continuum. Many states, when looking at innovative services, will look at this idea of directed payments. I know in my state, I live in New Hampshire, directed payments have been an opportunity for the state to innovate within Medicaid, particularly around behavioral health. So in this instance, these are services where it might not be part of the state Medicaid plan, but a state will determine that they want to have a new benefit in Medicaid. So what they will do is they will create what's called a directed payment, and the state will pay directly for that service. It's a much more, in some instances, it's more efficient to engage in pilot programs through directed payments and other things like that, while you might be working on whether or not something needs to be added to a Medicaid state plan. However, directed payments going forward because of HR1 are going to be capped and capped at Medicare rates. This could create a challenge in the opportunity for directed payments to really be utilized in the way that states have utilized them up to this point. Again, we haven't done any analysis as to how Oregon specifically uses this benefit and whether or not it would have an impact. But to the extent you hear of or think about services that are paid through directed payments, there would certainly be some impacts there because of this cap. And again, we anticipate about between 1 and 200,000 Oregonians losing coverage on Medicaid. So, a couple other impacts I want to reference in HR1. The first, and this ties to my point earlier around commercial insurance. All of you know that we had a government shutdown recently. And the reason that we had a government shutdown is the loss of premiums that were provided to folks who qualified for Affordable Care Act commercial coverage through the exchange. As you know, in real time, Congress, there has been no solution developed to that. As a result, people receiving insurance through the marketplace, as well as other ways, are seeing increases in their premiums this year that are outsized from what you would normally anticipate in terms of coverage increases year over year in the private market. The loss of subsidies in Oregon, there's been some press reporting that approximately 34,000 Oregonians are likely to lose marketplace coverage or not opt in to continue coverage. So I highlight this because while obviously there is a lot of attention to people who may lose access to Medicaid, there is a swath of the population who might be commercially insured who is also potentially looking at losses in coverage because they cannot afford the cost of coverage going forward in the absence of those subsidies. So to the extent that providers are serving people with commercial insurance, there is another sort of added piece of the types of individuals who may no longer be able to access care through commercial coverage. And again, driving up the utilization of crisis services, driving up emergency room visits over time. The other piece I want to just highlight really, really quickly is SNAP. Obviously, this is food assistance and not necessarily substance use related, but SNAP also comes with very significant work requirements. HR1 creates some other limitations and restrictions around SNAP. There's a desire in Congress, to the extent that work requirements exist in SNAP and in Medicaid, to try and align those, both from a policy perspective and an administrative perspective. I name that here because, again, for vulnerable populations who might be on Medicaid and have SNAP, you could see a compounding of challenges, right? And we know that that's going to add stress to individuals and families. That's going to drive people potentially into challenges with their mental well-being. So I just highlight that because even though it's not substance use related, it's an area that's going to have challenging impacts on probably a very similar population that the substance use field serves. And so certainly it's going to add stress that may influence and inform people's acuity if they're finding it difficult to access other services. And obviously, to the extent that providers are looking to connect patients who are in substance use treatment with services like SNAP programming, it's another layer of bureaucratic administration and another layer of increased regulations that's going to impact the ability to provide those folks truly wraparound services. I have a couple other slides and then I'll pause and we'll take questions. As I noted earlier, a lot of what I just shared is some of the negative stuff that's coming out of HR1 that we think it's important for you all to be attentive to. The other piece that's coming out of HR1, however, is a new investment in healthcare services across the country called the Rural Health Transformation Program. You may have heard of this. Some of you may have seen Oregon's proposal. This is a multi-billion-dollar initiative over 5 years to expand and stabilize the delivery of healthcare in rural parts of the United States. All states were given an opportunity to apply. Every state is receiving at least some modicum of dollars by formula, and then there are some additional dollars that will roll out to various states based on other factors. The state of Oregon has received a 5-year grant of $197 million a year. Those grant announcements were just notified at the end of December. Most applications, including Oregon's, are available online, but I highlight here just the priority areas that Oregon identified in its proposal, which aligned with CMS requirements for these dollars. So there's not a ton of detail in the proposal itself to get more down in the weeds on this, but again, there are some places where behavioral health, substance use disorders, and mental illness services are identified as an area that Oregon intends to work on. So there's, I think, 5 or 6 priority areas: regional partnerships and systems transformation to look at building coordinated networks of providers and improving care access and efficiency. There's some investments noted around preventative care models, community health, and population health level issues. Behavioral health is explicitly named here in Oregon's proposal, so that's a priority area that folks should pay attention to. There is workforce capacity and resilience efforts that are noted, strengthening workforce recruitment and retention, clinical training, support for rural health professionals. Again, and these priority areas are generally the priority areas every state applied on. So just to note that these are included. This is specific to Oregon, but most states structured their proposal in this way. There is a significant focus on technology and data modernization, focusing on expansion of telehealth, digital health infrastructure, interoperability between providers to connect with patients. Again, behavioral health and substance use disorder services are named as a focal area in Oregon's proposal around technology and data modernization. So that's something that you all will want to pay attention to. And as well, specific in Oregon, there is a set aside and a priority for tribal supports, and inclusive, again, of mental health and behavioral health support services. So some of these dollars will go to support those tribal initiatives throughout the state of Oregon. Again, these dollars were just announced. States have the time pressure to put dollars out is relatively aggressive in this first year. So I would envision, and I'm sure colleagues at OHA who are involved in this are probably well aware, there's a pretty significant push now across the country for states to start rolling these dollars out in contracts, whether that's through sole source, RFPs, et cetera. So I think this commission being attentive to where these dollars start to play out, what those proposals start to look like in terms of behavioral health will be something that you want to pay attention to. So just a couple of things just to summarize. We anticipate pretty significant administrative burden and churn in the Medicaid program because of HR1. A lot of the guidance from CMS, whether it's the work requirements, medical fragility exemptions, or some other elements of the HR1 changes, that guidance is yet forthcoming from CMS. So there's going to be some real challenges for states and state agencies and Medicaid offices to sort of find their way into implementing these as required within the timeline by law. We anticipate an increase in uncompensated care, care interruptions, and the crisis type services. So I think for providers who provide those services, or for all of you who are thinking about how do we best position the field to deliver care and tied to our comprehensive plan, this is definitely a series of changes that are going to create some challenges towards implementation that you'll all need to think about. Some of this as well is just going to be a burden on providers and create further provider instability. And that's absent additional revenue or other economic realities that may either prove opportunistic to support expanded providers in the state of Oregon, or to support them going forward. And again, some of that impact is not yet known. But this is going to create some infrastructure challenges at the provider level, as well as they start to see the impact of coverage changes among the populations that they serve. A lot of folks are paying close attention to the Rural Health Transformation Grant across the United States. Many see this as an incredible opportunity. But I do think what most have said, particularly advocates at the national level, is that although this influx of resources might be a welcomed opportunity to expand broad delivery of healthcare, it may not be enough to mitigate the Medicaid and other funding losses that are caused by some of these other elements of HR1. So this is going to be a period of some discord and resonance, where on the one hand, there's new resources to bring down. On the other hand, there are some changes coming, particularly in Medicaid, that may adversely impact the systems that you're all trying to build. So with that, I'm going to stop sharing. It was a lot of information. We'll have this slide deck available to all of you, but would love to just pause and see if there are any questions.
I'll just hop in and comment. Thank you, Tim. Probably should have prefaced this presentation. We wanted to bring this to you guys to start to make sure everybody has a very strong foundation and what the changes to Medicaid are going to be, so that we understand as a commission what our levers are within the state to protect people with substance use disorder and their coverage. So wanted to start with this good kind of national perspective before we start to move into Oregon decisions.
Yeah, Shira, go ahead.
Thanks, Tony. Shira here. I'm with Clatsop Behavioral Health Care in Clatsop County Community Mental Health Program. So, I think one of the most devastating things to happen to providers and to consumers is when we build new clinical programs and then we lose them a couple of years later. It's just such a significant waste of time and energy. The moral injury is awful. It creates a sense of distrust within our client population, that they can't rely on us. And so, just reflecting on burn dollars and the impact that this not very stable funding stream has had on provider organizations and communities, and knowing that we're looking at additional reduction in burn money, and also acknowledging the incredible stress and pressure that state leadership is under in trying to figure out what to do with this rural health transformation money that we know isn't going to be enough to offset med reductions. But I guess I would just ask that there be some consideration to utilize some of that money to offset the reduction in burn provider services, because I just can't, and I just thinking about losing additional SUD services because of the additional burn reductions is such a heartburn. And just thinking largely about how our substance use disorder system is not sustainably funded, I guess I would really just ask that OHA leadership strongly consider how to utilize the rural health transformation money in a sustainable way to prop up SUD services across the state. Thanks.
Thanks.
If I could add one other element tied to that, but just tied to decision making in general. And then Moxie, I see your question in the chat, which I can quickly answer. One other thing I will share with you all is, we've had a number of opportunities to brief various groups about HR1. And one of the questions that often comes up is, well, we have an election coming up. And is it, is it possible that an election could come up, or there might be legislative energy to go back and sort of address some of the inherent challenges that these changes are going to cause? Obviously, you're seeing some movement in Congress to still try and address the subsidy issue relative to the marketplace. But I think globally speaking, most states are operating to think through the need to implement this as it is, and that it is probably unlikely that November or something would create a really dramatic reversal that would make some of these challenges, because as I noted, some of what's coming in Medicaid won't come until 2027, et cetera. So this is not being implemented right now. And I think we've had some conversations with groups where they said, well, if the implementation doesn't start until 2027, or this doesn't go into effect until 2028, is there the potential that that could get reversed should a federal election turn things around and Congress revisits these policies? Most states are proceeding as if that's not an option, and that is probably wise. So I just want to name that, because I do think that some of the questions around how states adapt to this need to be answered, because there isn't a crystal ball to that. The other piece I would say too is that I think at the state level, I will just speak to other states where we've spoken to state agencies. Because there has not been fulsome guidance from CMS yet around implementation, there's still a ton of unknown. So it is possible that some of these impacts could be mitigated by guidance CMS gives. It's possible that there could be new negative impacts that are created by that CMS guidance, and that is a real unknown now. So it's just another place where I think making decisions with limited information is a challenge.